And so today we're going to be talking about details of the formulation and dosing of buprenorphine. This is a talk made by our very own Dr. Bhatt, who's not here today, but will present his information. And I'm sorry if I miss something in the chat. Feel free to interrupt me if I should pause while presenting these. So the objectives today are to describe the differences between different formulations of buprenorphine, discuss the difference between protocols of home-based and clinic-based initiation of buprenorphine, learn about dosing and duration of maintenance treatment, along with how to potentially manage diversion of the medication, and create a plan for managing the process of medical withdrawal when indicated from buprenorphine. So just to touch upon the formulations briefly, this is a wordy chart, but just so everyone has a sense, usually when you hear buprenorphine, we'll use the name Suboxone. That's the combo product, which is buprenorphine with naloxone, which is really there as an antidiversion mechanism in the medication. And you can see the forms are namely sublingual. Usually we'll be prescribing Suboxone, which is on most formularies. Occasionally we'll be using Subsolve, the tablet. And just to point out that the equivalent doses are 8 milligrams of buprenorphine to 5.7 on the Subsolve. There's also a buccal formulation, otherwise known as Bunavail, which I rarely see, but that is another formulation of the combo product. And then in the mono product, so just buprenorphine alone, which typically we'll just use in pregnancy, and in pregnancy now we're also seeing combo product, but typically when we're prescribing the mono product, it's in pregnancy. That comes in 2 and 8 milligram tablets. And then we don't use the implant, but the Sublocade, the injection, we do use quite readily, and that's a once monthly injection of buprenorphine. So again, this is kind of summarizing that table. We are going to be using that combo product most usually for treatment of opioid use disorder. And the reason for that second medication, the naloxone being there, is that really when taken as prescribed, that's not well absorbed, and so it's not going to cause someone to withdraw. However, if that medication is changed in its form and injected in someone who is on opioids, it can will precipitate withdrawal. So that's really an antidiversion mechanism when that medication was made. And you can see there again the 3 formulations and the use of the mono product in pregnancy, really, and if there's a documented allergy. And I will just emphasize allergy because oftentimes people may say they're allergic, and when you go into that a little bit more, it's usually more that they may have had some precipitated withdrawal when starting buprenorphine in the past, and that a combo product may still be something to try again. But we need to distinguish that from true allergy. In terms of the film versus the tablet, this was really driven mainly by third-party considerations. So how available and if the insurance is covering it. Usually now the film is covered. The film tends to dissolve a little bit quicker. Sometimes people have different responses in terms of the taste and tolerance of it and may prefer the tablet, but usually the film works well. And the individual wrapping is meant to make it safer and possibly decrease diversion, especially to individuals who could be harmed, such as children getting into medication. Still want to store it locked. In terms of the buprenorphine treatment options, looking at the difference between self-administration and administration in the clinic of the injectable. For self-administration, this really is the current standard of care. It's widely available. There's, as we looked at, different formulations and doses. I'm sorry about that. And the one thing to consider is that the diversion risk increases, certainly if someone has it, at home. The injectable form given just in the clinic, that one has less, I would say, clinical experience, but I think at least we see a growing number of patients who are tolerating that well. And there's, a growing number of doses and vehicles of administration. There's currently some in study now to help expand the options there. It is a closed distribution system, again, so that decreases the risk of diversion. However, it does have higher costs associated, so there's a bit of a PA process usually to have that one approved. So just talking about starting Suboxone at home, this is the standard of care. Is it feasible, safe? Is it effective? The answer is definitely yes. Josh Lee's study out of New York showed good outcomes, 7-year outcomes with an N of 485, basically had at least as good outcomes as clinic-based approaches, which was really when we were starting this back 2 decades ago, was sort of more what we learned to do was the clinic approach, but that's really shifted just in terms of both feasibility and really accessibility for patients. But you can see here, without reading all of the lines through, that it has good results with low risk of adverse events, serious adverse events at 0. Precipitated withdrawal, prolonged withdrawal were not increased when compared to starting in the clinic. And importantly, the median treatment retention at 57 weeks was also a good treatment outcome duration. That's really what we want to see, that people are staying in treatment. You might consider excluding or being more concerned if patients have a low tolerance to withdrawal in the outpatient setting. Those might be folks who will do better starting in an inpatient or in-clinic setting. Sometimes that also is for patients transitioning from methadone, as those can be more challenging starts. And then certainly if patients have cognitive impairment or untreated psychiatric conditions that are preventing them from being able to really follow the initiation instructions at home, that would be another potential concern for an at-home start. Certainly if there's an emergency such as suicidality, then we'd be referring them for care emergently, rather than going home. And certainly if patients, I think with patients with no prior buprenorphine experience, they are still good candidates for home starts, but may just want to make sure you're going over the instructions really carefully. I will say these days, a lot of people have already tried it, prescribed or not prescribed, and so are pretty familiar with it, but it's still good to go over that if they haven't had a prior prescription, or certainly if they have significant fear of withdrawal. So now we'll just kind of break down. This is a pretty standard approach that we're starting with to the buprenorphine starts at home. And then we'll transition to just looking briefly at some newer approaches that we're using really more in the time of our high potency synthetics, aka fentanyl. So really what we instruct people to do is wait on day 1 until they're feeling really pretty bad, really bad withdrawal. If they can extend that even more, giving comfort medications to help get to enough withdrawal so that we're trying to avoid precipitating withdrawal, which if you've taken the X-Waiver course or just heard about that, it's basically because buprenorphine is what's called a partial agonist, meaning it has that ceiling effect at the same receptors as other opioids. It can make people withdraw more if they have too much of a full agonist like heroin or fentanyl on board. So we wait at least 12 hours since the use of short-acting opioids and at least 24, preferably since the last of long-acting. You can provide your patient with a scale, which we'll look at on the next page here, the SOWS, and recommend that they wait for a target score if they're, that helps them to actually score it. It may of at least 17. And then we start with a 4 milligram dose usually, so you can instruct someone to cut that film or tablet in half, and then repeat that about every 1 to 3 hours if the withdrawal continues, which most likely will, for a total dose. And again, this is kind of our standard approach of 12 to 16 milligrams on day 1. And certainly to call the clinic if they're concerned. This is just a example of that SOWS scale, and you can see there people will score themselves from 0 to 4 based on how they're feeling on all of these potential symptoms that they experience in withdrawal. Then on day 2, you instruct them to take the total dose that they took in day 1 when they were gradually building up. First thing in the morning. So this is something that oftentimes people kind of miss this instruction, and we'll see them back in a few days and find that they're still taking like little bits throughout the day. That is not what the goal is, because I think that kind of recreates sort of needing to kind of take something very frequently, disturbing your day. It makes it hard to get on with what you need to do. And so it can help stability if you're just taking a long-acting medication once a day. So if they're able to take it once a day, they're going to take that first in the morning. But then later in the day, if they continue to have more withdrawal emerging, then they may need to take an additional 4 milligrams until they get to a maximum. And here it says 16, but really we're seeing people need upwards to 24 milligrams, even on day 1, but we'll stick to day 2 here to stay with this more traditional approach. And then on day 3, certainly again, be in touch with the clinic, can adjust the dose of their based on their response. And we usually would recommend giving someone enough of the medication for 1 week, so where they would need potentially up to 24 milligrams for that week, but based on what your clinic can provide in terms of when their next visit would be, you can adjust it based on that. But we try to get to that target dose quickly, whether that's 16 milligrams or otherwise in the first couple of days. And that's really one of the benefits too, when we're looking at buprenorphine versus say methadone, which we started our clinic too, is people can usually get to that target dose pretty quickly. And then once they've stabilized, we want to kind of wait about a week before reassessing to see if that is a good dose moving forward. So again, how long to wait before starting short-acting opioids? We counsel people about 12 hours, most of the longer-acting ones 24, and methadone at least 36 to 48 hours. And definitely want to discuss the possibility of precipitated withdrawal beforehand, not to discourage people, but so that they're not alarmed by it and know how to manage it, and also give them medications that may help in the case of that happens, because we do want people to push through the withdrawal rather than giving up on the start. And then just to touch upon transitioning from methadone, it's recommended to be on a lower dose of methadone, so 40 milligrams or less for at least a week, and then no methadone for at least 48 hours. Again, providing there's a list there of some of the medications that we frequently will prescribe for patients for comfort. And then once they're in enough withdrawal, again, doing that steady increase that we described of the buprenorphine. So again, in the case of precipitated withdrawal, this is not infrequent that this happens. Sometimes we get to that spot with withdrawal where when you take the buprenorphine, it does happen just in that moment to help turn around the symptoms. And that's what we want to try to counsel people to get to that point. But especially with fentanyl now, and just it can be hard to get there. So if observed, we want to continue to provide buprenorphine to get through it. Again, those medications to help with symptoms. And sometimes if someone's at home and this is happening and they can't get through it, we want to encourage them to seek care either in the clinic or if closed in the hospital. Okay, so now we're just going to shift gears in the last 10 to 15 minutes to talk about microdose and macrodose and initiation of buprenorphine, which is becoming more our approach, I would say, in the time of fentanyl. The standard approach, I think, still does serve in a lot of situations, but these are other ones to be aware of. So microdose inductions, the one we're going to look at first is a stepwise approach when someone is actually still on the full agonist. This was really studied more in terms of like treatment of chronic pain, patients who are on prescription opioids for that. However, it can be used in other settings. So this is when small buprenorphine doses are administered in a stepwise approach over about 7 days to reduce the risk of precipitated withdrawal and pain. Again, it could be particularly helpful for patients who have chronic pain or for those who just aren't able to stop using other opioids and can't really get into withdrawal, enough withdrawal, because it doesn't require withdrawal prior to starting. So unlike the ones that I just described. It does work because of that high affinity that buprenorphine has at the mu opioid receptor. So it takes advantage of that affinity to gradually push off, have buprenorphine started and gradually push off the other opioids that are there. But again, gradual is the key in this approach, so that it doesn't cause an uncomfortable withdrawal. And then after starting on buprenorphine, the opioid that was already there can then be tapered or stopped. So here's a diagram, picture depicting this approach. This one is over 7 days. You can see there we have someone start on day 1 with just 0.25 milligrams. So a very small amount of buprenorphine, and the idea is they would still be taking the other opioid during this time. So it's a very gradual approach where they would be cutting that film. Again, remember, it comes in a 2 milligram film. So in this case, they can cut that film and then eventually transition to an 8 milligram. But then they would go up to the 0.25 twice a day, step that up on day 3, etc., all the way up to day 7. In this method, getting up to 12 milligrams by day 7. And then the idea would be that there's enough receptor coverage at that point with buprenorphine, which again has a higher affinity than most of the other opioids, and then stopping the other opioid. So we'll talk about other microdose in the setting of fentanyl in a minute, but first we're just going to talk about what maintenance dose looks like. The FDA maximum is 32 milligrams, and most insurances cover up to 24 milligrams, so we make the case if needed for increasing that. It can be helpful just to get a sense of what your clinic's doing to track the mean, median, and mode of dose. So for most, I would say, people at some point want to know when they can get off of the medication. We do never encourage people to get off of the medication because the risk of relapse is high. But certainly if someone's been stable for a while, and if anyone wants, they usually come in saying, I want to know how long, which I discourage them at looking at it from a time standpoint, but I definitely encourage them not to consider it in the first year. But we really want to tie it to how they're doing in terms of their overall experience in life. Are they, reaching the goals they want to reach? Have things shifted in terms of employment, education, family, etc. And then in terms of the prescription, we start with weekly prescriptions here. Now, this isn't a rule. This is how we do it at our clinic. And so you would kind of need to assess what works best for yours. But we usually see people back weekly for, I would say, 2 to 4 cycles, and then go to 2-week prescriptions if they seem to have stabilized on their dose. Then monthly with a refill, and I would say up to 2 refills. We usually check in with people every 3 months. That would be the most that we'd go. As far as concerns of diversion, most clinics will be able to, will do the urine drug screen at each refill, but definitely we do those here. You can do them randomly as well, but it's appropriate to do them at the refill. And you want to make sure buprenorphine is included in that, and that can be sent, and it would be recommended at least a couple times a year to confirm the buprenorphine metabolites are present as well. Of course, we want to be checking our PDMP. You don't have to do 48-hour callbacks, but that is something that is maybe part of your treatment agreement, that's a possibility, so that if you had a concern, you could ask someone to come in within a certain time frame if there was a concern, to bring their medications to count. And then certainly we want to encourage safe storage. And now shifting gear in the last few minutes to our high potency synthetic opioids, namely fentanyl. So what we know is that most people are tolerating initiation with buprenorphine well. However, these initiations certainly can be much more challenging, as I'm sure most of you have already encountered. We do see some increased reports of precipitated withdrawal. We also, though, see that retention and treatment, which again is key to survival, appear equivalent. So the study from Wakeman in 2019 in folks who were started on buprenorphine for heroin versus fentanyl. We don't fully understand why we see more precipitated withdrawal. It's possible it's due to reduced, with fentanyl that is, it's possible it's due to the renal clearance. Possibly that it's a lipophilic drug, so more long acting over time. And interestingly, it's not seen so much when a fentanyl patch is replaced, and this is what we tend to see in inpatient settings with a buprenorphine patch. So it seems to be with the sublingual. So now we're going to just touch upon microdose initiations again, but this is kind of in the setting of these high potencies opioids. So the key to microdose approach here is starting low and going slow. However, unlike the other slide that I showed you, this is when someone has stopped using the fentanyl, they're going to wait longer to go into withdrawal. So sometimes 24 to 48 hours, and really aiming for a higher initial. This is the COWS score. I had shown you the SOWS before, but the COWS when they're in clinic, usually for the like when we were taught about starting buprenorphine for heroin, let's say we would aim for a COWS of at least 8 to 10. Here we've got recommendation to aim for at least 13 to 15. Self-report, sometimes reliable, sometimes not so much. So hopefully we have that COWS scale to go by, but we do want to provide the same counseling and education on the risk of withdrawals, also provide those same adjunct medications that can help with comfort and increase the likelihood that someone can tolerate this. And then the microdose is giving about 1 to 2 milligrams every hour or so, aiming to get to 8 milligrams twice a day by day 2. However, I think what we're seeing more commonly is even on day 1, people need to sometimes get up to those higher doses, like 24 milligrams. The lower doses are more what we would recommend when people don't necessarily have the tolerance that we see most people coming in on if they're just recently using fentanyl. And then just remembering that some people may need a full agonist, and so methadone being an option if this does not work. This is a small case report from 2020, looking at 4 individuals, so 2 who completed the traditional approach to starting buprenorphine when they were on fentanyl, and 2 who did the microdose. And what they concluded was that the microdose improved withdrawal outcomes in the 2 who were on that. And then we'll just conclude by talking about the macrodose in the last few slides. Just checking the time here. I think we're good. So this study from 2020 from Lee looked at basically over 2 to 3 days getting up to a higher buprenorphine dose and transitioning to the 300 milligram Sublocade injection. So what you can see here in these 5 individuals, when they started, they came in with these varying COWS scores between 10 and 16. They were given their first dose of sublingual buprenorphine, but some even by day 2, but certainly by day 3, they were given the Sublocade or extended release buprenorphine injection. And you can see that by day 4, their COWS had really decreased significantly, 0 to 4, and that they were followed for the 3 monthly injections, and they had not used since starting, and we're still in treatment. Then a follow-up to this macrodose approach was the 1-day inductions. This was phase 2, and these individuals were given a test dose of the sublingual 24 milligram right from the get-go. This is the real macrodose induction, and then if they tolerated that, immediately were given the Sublocade 300. And you can see as well that their COWS scores were minimal, with again outcomes showing a couple with intermittent heroin use, some with none, and all remaining on treatment. Okay, and so also just touch upon withdrawal. There's really, if someone is again wanting to go through tapering down and off of the buprenorphine, we try to support them in that. Wouldn't, as I said before, encourage it, but if they're at a point where they're ready to, we don't have data to guide someone in terms of how long they should be on it, but we do have data about relapse and overdose risk when off of it. Studies as long as 16 weeks do show these high relapse rates with withdrawal, and brief withdrawal periods are unlikely to result in long-term abstinence. From this study 20 years ago from Kako et al., we saw that patients can be stay on the medication long-term, retain in treatment, and that we see 75% retention in treatment at 1 year when they're taking their buprenorphine still, but that there was loss of treatment quite significantly when they were tapered before that. So we really want to continue someone on treatment as long as they're benefiting from it in terms of all of those goals and their overall stability. As far as when someone is tapering, there's really no difference in terms of outcomes or advantage with a longer over a shorter taper. And again, the risk of overdose is greater after tapering because of that loss of tolerance. So if someone is going to use, and especially if they hadn't used fentanyl before, they taper off of it and then they encounter fentanyl, of course, that is at least much more dangerous as well in terms of that risk. So if we do proceed with it, we want to again check to make sure that those functional goals are being met, really that they're stable in terms of their social networks. And because we really don't have data that suggests one length of taper is superior to another, we really just want to go gradually if possible at the person's pace. And also with their understanding that tapers can always be reversed too if they decide that they midway that they don't want to. We want to try to continue to engage them in treatment, therapy if possible, groups if that's helpful to them. And then considering also the antagonist naltrexone upon completion of withdrawal possibly as something that could help decrease the risk of relapse. Okay, so I think we got through by 12:35. I'm going to stop the share, and I think, I'm sorry I didn't see any of the chats, but